I'm honored and privileged for this invitation. Thank you so much, Dr. Shatti. It's an honor for me to present to this esteemed crowd. I will briefly update you on high-grade endometrial carcinoma, talk about the molecular classifications and how can we implement it and incorporate it to our daily sign-out and in our classification or in every lab as well. We're all familiar with type 1 and type 2 endometrial carcinoma. Briefly, type 1 is endometrioid or mucinous. Patients are younger, probably around 40 to 60 years old, hyperestrogenic status. They are, most of them, diabetic and, as I mentioned, obese. The prognosis is way better than type 2, and in general, it is good. The precursor lesions is a typical hyperplasia, or what we call it nowadays EIN, endometrial intraepithelial neoplasia. The molecular event, mainly PTEN, ARAD, and microsatellite instability. If we compare it to type 2 by default is high-grade carcinoma, and it is either serous or carcinosarcoma. Generally occur in elderly patients. And we used to call them skinny patient, but not anymore. Even obese patient can be affected. The precursor lesions is serous intraepithelial carcinoma. And we emphasize on the word serous because we don't want it to be confused with EIN. The prognosis is bad in general, and the molecular event mainly P53 mutation. Grading endometrioid carcinoma in general, we depend on FIGO grading, grade 1, 2, and 3, and the emphasis today on grade 3. But briefly, grade 1, when you have solid cytologic malignant, less than 5% of the entire tumor. So it's really all glandular and very well differentiated. Grade 2, when you have the solid sheets of malignant cells, from 6 to 50, the range is really wide. And we call grade 2 is the wastebasket, when we cannot put it in 1 or we cannot put it in 3, so we put it in 2. Grade 3, and this is where we're emphasizing today the talk about, it is 50% of solid mass, solid malignant cells. And most of the time, these cells have pleomorphic nuclei, coarse irregular chromatin, and prominent eosinophilic nuclei. The squamous differentiation is very common in endometrioid carcinoma, but we do not include it in the assessment of solid growth. I like to emphasize also that grade 1 and 2, if we make the two-tier system, we call 1 and 2 low grade, and grade 3 is high grade endometrial carcinoma. Is this really the perfect grading system? Absolutely not. Do we agree together, if I look at one tumor and my other GYN pathologist colleague look at the same one, do we agree? So the reproducibility of this system is really poor. And if you look at this table, there is so many grading system, and a long time ago when I was young, I participated in one of them. So if it is the binary grade or the grade 1, 2, 3, or if you take each one of the architecture score, the nuclear score, it's not reproducible. So it's really low, and it has a lot of problems. I always go back to this table from Dr. Soslow from Sloan Kettering, and it helps differentiate between FIGO grade 3 endometrioid and serous carcinoma because there is so much overlap between both of them. And the magic word between all of this, I want to emphasize that it is when we say cells in serous carcinoma are discohesive, and they are more cuboidal than columnar. I know it's soft finding, but believe me, it helped me a lot. The FIGO grade 3 endometrioid, they are more cohesive, they are more sheets, and they are connected together. This is talking about the cell shape and the cytoplasm. The architecture, it is different. It's complex and glandular or sheets, and the sheets are more than 50% of an endometrioid. However, serous, it's most of the time, not always, papillary. You can see micropapillary, or you can see glandular. And the highlight of serous is the discrepancy between the glandular and the cytologic atypia. The cytologic atypia is really, really significant. And I'll show you a few examples. Again, this is in general, it helps, but all of this are soft finding. So in H&E, if you look at both, you might argue with me that both are serous, right? No, this one, which is on my right side, it's more papillary, and the lining of the cells has significant cytologic atypia. The other one, the cells are more cohesive, and these are FIGO grade 3 endometrioid carcinoma. Well, they can be the serous and the high-grade endometrioid carcinoma in one specimen. So the tumor can be mixed, high-grade endometrioid and serous, like in this example. That was a couple of years I had this case. And if you zoom in, you can see the endometrioid component and the serous component. And this is where I can tell you the difference between both, the cohesiveness and the sheets of cells on the right side, and that fragmentation and discohesiveness on the cells, and the glandular lined by significant cytologic atypia and the debris within the glands. If you look at the apoptosis and few necrotic cells, and this is from the turnaround of the proliferative activity of these cells, it's very high grade. And if we look at these two, you can also argue with me that both are serous. No, the one on the right side, look at what's in the lumen, very much necrotic and debris, and we call it schmutz. And this is from the proliferative activity of the cells, versus the other one, it's viloglandular, and this is low grade. It's not even high grade. But we cannot depend also only on the papillary configurations. It's the lining that the significant cytologic atypia, it's the highlight of serous carcinoma. And I tell the resident, serous is very serious, so you cannot miss it. So after all of this, I know that the histotype assignment in high-grade endometrial carcinoma is unreliable. So H&E is unreliable. And if it is even among expert pathologists, and they reported in the literature. So we really need more stratification, and particularly to guide the therapy for these tumor. So TCGA, a few years back, probably now 15 years back or more, looking at 373 endometrial carcinoma, and they performed genomic, transcriptomic, and proteomic analysis, divided endometrial carcinoma into 4 subtypes: the poly-ultra mutated, the MSI hypermutated, copy number low, which is non-specific molecular profile, and copy number high. And you can see it from this picture here. So the first one is the poly, the ultramutated, the second one, the MSI hypermutated, the third one is copy number low, and the last one, copy number high, serous. So when they implemented and looked at the H&E, this overlapped in this cohort beautifully. And even with Kaplan-Meier showing, I'll show you Kaplan-Meier later, and I'll explain this as well. So the grade 1 overlapped with the poly-ultramutated, and the patient did wonderful. The grade 2 overlapped with both MSI hypermutated and copy number low. The high grade, grade 3, overlapped with the serous-like copy number high. So apparently, if we know how to grade endometrioid carcinoma perfectly, this molecular subtype overlap with our grading system. But life is not black or white, right? So there is a lot of gray zone, which is problematic for our patient, particularly in the poly-ultramutated. So polymutated, it's not always low grade. It can be high-grade endometrial carcinoma on H&E and most likely reflect on endometrioid grade 3, and it can be even mixed. Both nuclear grade and mitotic index are high in a lot of the time, and it is associated with peritumoral lymphocyte TILs and lymphovascular invasion, in addition to few times you see giant cells. But the most important things when we do P53, it's wild type. And it is negative for P16 and normal mismatch repair protein expression. It is only 7%, but most of the time, unfortunately, this patient population are overtreated because on H&E, some of them, they look like high-grade endometrial carcinoma, but P53 negative. So this is why I'm emphasizing on this subtype a lot. The next one is the microsatellite instability, the hypermutated. It's composed of 28% of this cohort, and it can be of varying grade. Grade 1 can be here, 2, or rarely 3. And it has prominent lymphocytic infiltrate, but we have loss of MLH1 most of the time. So there is microsatellite instability and exhibit P10 and PIK3CA mutation. The third one, the copy number low, it's composed of 39% of the cohort, and the microsatellite are stable, MMR protein are intact, no specific molecular profile, endometrioid carcinoma, most of the time low grade. It has high frequency of beta-catenin genes in 50% of cases. And finally, the last group, copy number high, which is cirrus-like, it's composed of 26%. It has the features of cirrus on H&E. It's high grade, exhibit P53 mutation and aneuploidy. But is there any overlap between all of them? Again, as I said, it's not a black or white. So let's focus on the polymutation and look at the first column and see the overlap between all of these cases. So if we look at the polymutation, it has cirrus-like atypia on H&E in 90% of the cases. So only 10% has low grade. It has tumor infiltrative lymphocyte and peritumoral lymphocyte. Well, if you look at the P53 aberrant group, like the number is 18 in this study, and look at the overlap in the cirrus-like, 72%, in the tumor infiltrative lymphocyte, 50%, peritumoral lymphocyte, 67%. So there is a lot of overlapping. It's not specific when we look at only the H&E, but can enhance detection in presence of these features with a help from immunohistochemistry. So again, let's look at these two examples. One of them is copy number high, and another one is polymutation. But on H&E, can I say this is low grade? No, these are high grade and cirrus-like carcinoma. And these are the example for the lymphocytic infiltrate, the TILs, that I thought I will give you an example of it, and it is associated mainly with the poly and other carcinomas as well, other types. So one more time, the molecular subtype classification shows grade 3 endometrioid carcinoma to comprise of a mix of molecular subtype rather than homogeneous group. And this is why immunohistochemistry can be helpful. So we do, like routinely on every endometrial carcinoma here in the state, we do the MMR proteins and we do P53. This is on every endometrial carcinoma comes to our lab, and this is the routine in every endometrial carcinoma here in the state. Do we do P10, P16, ER/PR? No, we don't. And how do we read P53? As I said, it should perform on every high-grade endometrioid carcinoma, and now it's this presentation is a little bit 1 year old, so We perform it on every endometrial carcinoma. We have to differentiate between the wild type and the aberrant expression. So we don't call it positive negative. We call it wild type. If you have a few positive cells and the rest are negative, we call it wild type. It's very important that your control is working well and the internal control of the slide working very well. On the second hand, the apparent type, it's when you have diffuse or strong positivity. We say as if it's Christmas tree, like lighting up, or entirely negative. We favor serous carcinoma and we call it aberrant expression or aberrant type. This is a few examples of, as I said, Christmas tree, aberrant, with the overexpression of P53, the left one. The right one, it's completely negative, and it is the nonsense mutation of P53, which there is no antibody to express. So this is why it's completely negative, but the mutation is there. This is why we call it aberrant type or aberrant expression. For the last 5 minutes, I'll show you a few proposal algorithm to try to implement it in the lab and see if we can classify this endometrioid carcinoma better. The first one was to do immunohistochemistry for the MMR, MLH1, MSH2, MSH6, and BMS2. And if it is deficient, you go to the MSI and you do it by PCR. And then by Sanger sequencing, you do the polymutation and then the P53 by immunohistochemistry. Is this in every lab, even in the state? Absolutely not. We do not do sequencing for every endometrial carcinoma comes to our lab, even at Wayne State. But other labs, yes, we can send it to a major company, but this is a different topic by itself. Again, one more time, I'm talking about the challenge that on H&E, the intra-observer reproducibility is low, even among experts. In this study, the first one I highlight, Dr. Oliva, Soslow, and Gilks, they looked at high-grade endometrioid carcinoma, and they could not agree among themselves and between each others. So, and the genomic heterogeneity for FIGO grade 3 endometrioid carcinoma, it really impacts the diagnosis and the treatment for the patients. So in 2016, in a workshop done by the International Society of Gynecological Pathology, they put some recommendation how to make it simple and how to implement the molecular classification into our daily life in the lab. So they came with this PROMISE algorithm, which is proactive molecular risk classifiers for endometrial carcinoma. As simple as we do the MMR for every endometrial carcinoma. If you can implement it by MSI, that's wonderful, but immunohistochemistry is sufficient enough. If the lab has the capacity to do the polymutation, that'll be great, and P53. And this was able to recreate the 4 prognostically significant subtype of endometrial carcinoma. And looking in this table, and really you could look at the surrogate marker genetically and the surrogate markers by immunohistochemistry. And if let's start with it, do we have polymutation? If yes, then you are in the ultramutated subtype. Most of the lab, you don't. We do not have it. We don't do it in our lab. MSI high, looking at the genetic surrogate markers, it reflects to the MMR deficient. It's the same. If you do not have the MSI, you can do the immunohistochemistry, and it reflects on the hypermutated type. Next, P53 mutation. If you have it, it reflects on the copy number high. By immunohistochemistry, P53 aberrant, it reflects the same, copy number high. Well, let's say The absence of the other markers from the genetic, it reflects on the copy number low. If you have absence of other markers like p53 wild type, if it reflects on the copy number low. So as simple as immunohistochemistry and H&E, we can implement this molecular classification, even if you don't have the high tech by doing MSI or doing sequencing the tumor for the polymutation. And nearly all serous carcinoma, I know it's a little bit busy table, and especially I'm talking and I cannot tell you, it won't show the slides that I'm showing, or the arrow is what I meant. In general, nearly all serous endometrial carcinoma had p53 mutations, and the molecular classification system shows a high likelihood that p53 mutations is correlated with high-grade carcinoma. So this image or this table, I'm showing how important is p53. If it is by immunohistochemistry or the mutations, it reflects in this highlight lines the high grade 3 endometrioid carcinoma and serous. If you look at the p53 abnormality is very high. So another algorithm was proposed, again, if you have the poly hotspot mutation, if you do have it, so the patient has the poly mutations and they'll do good even if they have high-grade endometrioid carcinoma. So you stop there and you do not have to do the rest. Again, we do not have the hotspot mutation. We cannot do it in our institution. So we do not use this algorithm, but I thought I'll propose it to you and I'll show it to you. So if you have it, you stop. If you don't have the hotspot mutation, I meant the tumor. If it is positive, you stop. If it is negative, you do MMR. If the MMR lost, then it reflects the MSI high. You have endometrial carcinoma with, copy number low, or you do have the MSI high. If it is retained, you do the p53 normal, copy number low, abnormal, copy number high. It's just very simple and it can be implemented, and it is just reflecting on H&E, immunohistochemistry, and you need only for the hotspot. And there is a mutation for the poly, and there is so many labs they can do that. And finally, how's the reproducibility for the promised molecular classifications compared to the histiotype of the classification that we have? You can see from the highlight the kappa level of agreement. When the kappa level of agreement close to 1, then you have high reproducibility. Whenever it is low, it's then really bad. So you can compare between the first one and the second one. So the kappa statistics for simplified histotype was worse than high level of reproducibility seen within the molecular subclassification. And the kappa level of agreement is almost 95% in the promised molecular classification versus the histiotype. So it's near perfect. Remember, in pathology, there is nothing 100%, okay, and particularly in classifications. So finally, the molecular classification benefit, it's benefit our patient, and this is who you are catering to. And the molecular classifications are more reproducible and accurate than using histomorphology and grading system. And jumping to another option, we have biopsy, we have the DNC. So if we can run this molecular classification on the biopsy, we can provide even more personalized and individualized care without putting the patient at risk for treatment that they do not need. So the genomic results from the cancer specimen can assist in providing clinician with target treatment regimen. Talking about the biopsy and do the classification, we were one of the first people looking at the biopsy and implementing the molecular classification and comparing it to the hysterectomy. And this is our paper, the first one, comparing it with a way higher or larger cohort from Vancouver, and they did the similar study. And with that, hopefully the future will tell us, and we can implement this classification on the biopsy and the DNC before even reaching the hysterectomy, and the patient can be treated like individually. With that, I will finish. And again, thank you so much for letting me share this lecture with you, and good luck, and thank you so much. If you have any questions, please email me, and I'll leave my email. It's rle@med.wayne.edu.